Welcome to Pediatric Case Review. In this episode, we will continue into the presentations of febrile seizures among pediatric patients. Let's begin. Case number 7. A 4-year-old boy, previously healthy, develops a fever of 38.8 and a generalized seizure lasting 12 minutes. Over the next few hours, he becomes increasingly drowsy and confused, with episodes of unexplained crying and aggression. There are no signs of neck stiffness or rash. What diagnosis should be considered in this scenario? A. Simple febrile seizure. B. Complex febrile seizure. C. Viral encephalitis. D. Iron deficiency anemia. The correct answer here is C. The combination of fever, seizure, and the subsequent changes in behavior and consciousness suggests a possible central nervous system infection like viral encephalitis. Simple febrile seizure typically doesn't lead to prolonged altered mental status or behavioral changes post-seizure. Complex febrile seizure could account for the seizure's duration but doesn't typically cause prolonged confusion or behavioral change. Iron deficiency anemia can cause lethargy but isn't associated with seizure, and the acute change in the mental status seen in this case. 8. A 3-year-old boy experiences a 9-minute seizure during a febrile episode with a temperature of 39. He has no history of previous seizure and his development has been normal. After the seizure has quickly returned to his normal baseline behavior. What is the most appropriate next step in evaluation of this child? A. Perform a lumbar puncture immediately. B. Conduct a thorough clinical examination and assess the cause of the fever. C. Order a complete blood count and serum electrolyte panel. D. Schedule an EEG. The correct answer in this case B. In a child with a typical history of simple febrile seizure and a non-focal clinical examination, the most important step is to perform a thorough clinical examination and assess the underlying cause of fever. This includes looking for signs of respiratory or ear infections, which are common cause of fever in this age group. Performing a lumbar puncture is not routinely indicated in well-appearing child with simple febrile seizure who returns to baseline post-seizure. Ordering a complete blood count and serum electrolyte panel is generally not necessary in the absence of symptoms like vomiting, diarrhea, and dehydration. EEG is not indicated following a single simple febrile seizure in a neurologically healthy child. Case number 9. A 6-month-old infant with a fever 38.6 experiences a generalized seizure lasting 5 minutes. The infant is up to date with immunizations but appears lethargic post-seizure. Considering the age and post-ictal state of the infant, what is the most appropriate next step? A. Immediate neuroimaging. B. EEG. C. Lumbar puncture. D. Observation and fever management. The correct answer is C. In infants, especially those under 12 months, the presentation of febrile seizure can be less specific, and the signs of meningitis may be subtle. Given this infant's age and lethargic state post-seizure, a lumbar puncture is indicated to rule out central nervous system infection. Immediate neuroimaging is not routinely indicated for simple febrile seizures. An EEG is not typically useful in the acute setting of simple febrile seizures. While observation and fever management are important, they shouldn't replace the need for lumbar puncture in this age group, given the potential risk of central nervous system infection. Case number 8. A 1-year-old child with a history of mild dehydration due to gastroenteritis presents with a fever 39 and a generalized seizure lasting 8 minutes. Post-seizure, the child is alert and active. Given the history of dehydration, which additional tests would be most informative? A. MRI brain. B. Serum electrolyte panel. C. Blood culture. D. EEG. The correct answer is B. In the context of recent gastroenteritis and mild dehydration, a serum electrolyte panel is important to check for electrolyte imbalances, such as hyponatremia, which can lower the seizure threshold and potentially contribute to seizure activity. MRI of the brain isn't indicated in the absence of focal neurological signs or a history suggesting a central nervous system disorder. White blood cell count can be important in the workup of fever. It is not specifically indicated based on a history of seizure and gastroenteritis unless there are other signs of serious bacterial infection. An EEG is not routinely indicated after a single simple febrile seizure in a neurologically healthy child. Case number 11. A 3-year-old child experiences a second simple febrile seizures within 6 months. The seizures were generalized and each lasted less than 10 minutes. The child has no neurological deficits and is developing normally. Given this scenario, which statement most accurately reflects the appropriate treatment and prognosis for this child? A. Long-term anti-epileptic drugs are recommended to prevent further seizures. B. This child has a high risk of developing epilepsy later in life. C. Intermittent anti-epileptic therapy should be administered during febrile episodes to prevent seizures. D. Routine use of continuous anti-epileptic drugs is not recommended as the child has a good prognosis with a low risk of developing epilepsy. The correct answer here is D. For children with simple febrile seizures, the use of continuous anti-epileptic drugs is generally not recommended due to their good prognosis and the low risk of developing epilepsy. This is particularly true when there are no neurological deficits and normal development, as in this case. Long-term anti-epileptic drugs are not typically used for simple febrile seizures, as the risk of complication often outweigh the benefit, given the typically benign nature of these seizures. While this child has experienced more than one febrile seizure, the overall risk of developing epilepsy remains low. Simple febrile seizures, even recurrent ones, don't significantly increase the risk of epilepsy. The effectiveness of intermittent antibiotic therapy in preventing febrile seizures is not well established. Febrile seizures often occur at the onset of fever, sometimes before antibiotics can be administered. Case number 12. A 4-year-old boy with a history of multiple febrile seizures is brought to your clinic. His seizures are usually associated with high fevers and tend to last longer than 15 minutes. His father and paternal uncle both had febrile seizures in their childhood. Considering his family history, which of the following is most likely? A. The boy's febrile seizures are purely incidental and not related to genetic factors. B. The boy may have an increased genetic susceptibility to febrile seizures. C. The family history suggests an autosomal recessive pattern of inheritance for febrile seizures. D. The presence of febrile seizures in the father and the uncle indicates a high likelihood of the boy developing epilepsy. The correct answer is B. The presence of febrile seizures in first-degree relatives, father and uncle, suggests an increased genetic susceptibility to febrile seizures in this boy. A family history of febrile seizures is a known risk factor. The occurrence of febrile seizures in a family member doesn't imply that they are incidental or unrelated to genetic factors. In contrast, a family history often points towards a genetic predisposition. While there is a genetic component to febrile seizure, the specific inheritance pattern, such as autosomal recessive, is not well defined. In most cases, the pattern of inheritance can vary and is often complex. A family history of febrile seizure doesn't necessarily equate to high likelihood of developing epilepsy. While there is a slightly increased risk compared to general population, the majority of children with febrile seizures don't develop epilepsy. Thank you for joining us. Stay tuned for more pediatric case reviews.